We're going to talk about mass screening. Basically, is it time to do this? Is it a good idea? Or what are the drawbacks to doing mass screening for celiac disease? I'm not getting paid for this. I'm just here to talk to you guys about this. First thing to recognize is that, celiac disease is not rare at all, right? It's actually relatively common. In the U.S. population, we estimate it's about 1%, overall. But we always think that it's higher in Europe. So in Finland, it's quoted to be as high as 2% in the general population. And even in Sweden, for these children that were born during what we call like the celiac disease epidemic from 1984 to 1996, it turned out that 3% of kids who were born during this epidemic, when they became adolescents, 3% of all 12-year-olds had celiac disease at that point. So we do know that the incidence is rising, okay? And it's not just because we're picking up more cases because we're thinking about it more. We do believe that it's because more and more people are actually developing celiac disease. So should we be performing mass screening for this then? Like I said, it's common. Why shouldn't we be doing this? We know that there's a large number of cases that remain undiagnosed. And we also know that untreated celiac disease can lead to complications. In the screening test, the tissue transglutaminase TTG antibody test, it's simple and it's safe. So, why shouldn't we be doing this? But obviously there's a lot of questions that remain unanswered that we should explore. So NASPGHAN, that's the Pediatric GI Society. It's a North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. They recommend screening certain individuals for celiac disease, and it's basically individuals who have a higher risk for this condition. Okay, and those include individuals with type 1 diabetes, autoimmune thyroid disease, kids with Down syndrome, Turner syndrome, or Williams syndrome, those with what we call selective IgA deficiency. I should add on here also those with juvenile chronic arthritis and autoimmune liver disease, but also importantly, those who have a relative with celiac disease. And so, if we screened individuals just based on these risk factors, though, we'd be missing most of the cases because most people actually don't fall into any of these risk groups. Most people don't have a family history of celiac disease. So if we were just to do this kind of screening, we'd be missing a lot of individuals. So who do we typically test, though? In general, it's those people who have symptoms. And celiac disease can present in many, many ways, though, right? So we have what we call now classical celiac disease. And these are the individuals who have like the typical GI symptoms, symptoms of malabsorption, abdominal pain, bloating, constipation, growth failure, those things. And that's more common in the younger group, okay? But we also have individuals that we call non-classical celiac disease. And these are individuals who have sort of like the non-GI type symptoms, so what we call extra-intestinal manifestations of celiac disease. And oftentimes it's more like the older individuals. There's also a group that we consider to be subclinical, though. And subclinical celiac disease is basically having celiac that's below the threshold of clinical detection. So it may mean that you have symptoms, but it's just not bad enough to go see your doctor for. And there's a last group, though, that's truly asymptomatic. And so these are people who have no signs or symptoms of celiac disease, but yet they have the autoantibodies, they've got injury in the intestines, they have it, they just don't feel bad, they don't have any symptoms that we can tell. So if we were to do targeted screening just based on individuals who had symptoms, again, we'd be missing a lot of cases. It turns out that about half of all individuals with celiac disease fall into like the asymptomatic or subclinical category. So this wouldn't be very effective if we wanted to try to catch everyone with celiac disease. So we're going to go back to the genes again. Okay, so Ivor mentioned the HLAs, DQ2 and DQ8. Right? And these are the major genes for celiac. And in general, if you have DQ2, it's seen in about 90% of all individuals with celiac disease. It's the big gene. DQ8's a lesser risk, but it's seen in about the rest, 8 to 10%. And without either of these genes, the risk of getting celiac is extremely low. It's not zero, but it's very low. And it's important to note also that having DQ2 or DQ8 doesn't necessarily mean you have celiac disease, it just means there's a risk. Okay, so again, just to emphasize, having these genes does not mean you have celiac disease. So as Ivor pointed out, 40% of the general population has risk for this. And we see this in Denver too. So in one of our studies, we've screened almost 32,000 kids from birth, infants, by testing our cord blood for their genes. And when we look at this, we can start to look at the distribution of these HLA genotypes. So remember, you inherit one copy of the gene from mom and one from dad, so you can have two chances of getting DQ2 or DQ8. And so individuals who have a double dose of DQ2, that the frequency of this is actually relatively low. Even though that's the highest risk for developing celiac, not many people have a double dose, so it's about 1% of the population. The big risk here is if you have a single copy of DQ2 and X stands for something that's irrelevant. So if you have a single copy of DQ2, the frequency of this is actually seen in 17% of the population, okay? So you can look at those who have DQ2, DQ2, those who have DQ2, DQ8, okay? Those who have DQ2 with an irrelevant additional gene, those who have two copies of DQ8, and those who have a single copy of DQ8. And it turns out, like I said, 40% of the population, but keep in mind that that means 60% of the population actually doesn't have a gene that puts them at risk for celiac. So, in this study that's being conducted in Denver, it's called the DAISY study. We've been following these kids out for like 20 years now, and we're following 39 kids from Colorado who have these high-risk genes. And so from birth, we check their TTG antibodies every year, and we look to see when they actually develop antibodies. And so looking at the development of autoantibodies, you can see, as Ira pointed out, having a double dose of DQ2 is a high risk, followed by those kids who have a single dose, followed by those who have DQ8. All right, and so you can see that the development of these antibodies in kids who just have the gene can occur pretty quickly. And when we look at this for celiac disease in general, it turns out that the estimated cumulative incidence of celiac disease in the general population is about 3% for kids by age 15. So this is really high. This is similar to the numbers that they found in Sweden when kids had that celiac disease epidemic that was in the 80s and 90s. Okay, so the way we can estimate this is because we know the contribution of each of these genes. We know the risk of having celiac disease for each of these gene combinations. We also know how frequent these genes are in the general population, so we can estimate this. And you can see that for the first 10 years of life, more and more kids develop celiac disease, but then after 10 years, the new cases seem to drop off. Okay, and we have no idea what happens in adults, but we do feel like if kids get it, they're going to get it pretty early, and then as they get older, it probably slows down. So the conclusions from this study are that all you need is DQ2 or DQ8 to actually develop celiac disease, even without a family history and even without symptoms. Keep in mind again that not all individuals with DQ2 or DQ8 are actually going to go and develop celiac disease though. And when you get it, it oftentimes occurs quickly in childhood. And it certainly doesn't mean that adults can't develop it spontaneously. They can. And the rate of celiac development really slows down after age 10. So this has some implications for like mass screening if we were to do that. One thing I didn't show you is that up to 5% of all Colorado adolescents in our study actually developed antibodies at some point in their childhood. Okay, but not everyone with even antibodies will go on to develop celiac disease. Sometimes people can actually have antibodies that go away on their own. Okay, but there does appear to be an increased incidence of celiac disease in the Denver general population. And like I said before, we're finding that it's about 3%, which is really high. We don't know yet if this is applicable to other places in the US, but we don't really have a reason why not, but that's the next study that we're doing right now. And keep in mind that this 3% that we're finding in Colorado is really similar to reports in Finland and also in Sweden. So if we were to do general population screening then for celiac disease, there's probably two ways that we could do this. We either first perform HLA gene testing, right, and identify only those who have a genetic risk where you would do testing with the antibodies for, or you can just do mass screening, meaning testing everybody. And I think there's pros and cons of this, and a lot of this relates to cost. But certainly either approach is going to require multiple time points for screening. So you can't just screen once and be done with it, right? Because no one's born with celiac disease. this is something that develops over time. Maybe you would test it after age 10 because most kids will develop it by then. But typically what we would do is we test it at certain time points throughout childhood. So then what's the holdup for doing mass screening? Why aren't we doing this? And there's a lot of considerations for this. First thing is, in someone who's asymptomatic, no symptoms at all, are we causing any harm? I mean, is it really necessary? Are we causing harm in doing screening? So we know that there's considerations that if you test everyone, you're going to cause a lot of anxiety, potentially depression in individuals who are being tested and identified as having antibodies that are positive. What about in diagnosis? Not everyone with antibodies will actually go on to develop celiac disease, and that can lead to a lot of unnecessary biopsies. And then in treatment, so, I ever talked about the burden of treatment, and if you're asymptomatic, are we going to be negatively affecting the quality of life? So, like I said, a lot of considerations for this. And also a very important question is there really a benefit in treating someone if they're asymptomatic? Meaning, are we actually improving their health? And the main rationale for treating someone who's asymptomatic is that we want to prevent complications in the future. And I think the hard part here is that not everyone with asymptomatic celiac disease is actually going to develop complications. But certainly, my bias is that, especially if you're a child, a child's job is to grow and develop, and we don't take those chances. But this is a really rich area to study. And when you think about policy, is it really cost effective to screen everyone for celiac disease? So this is really timely, but just last month, or a couple months ago, the U.S. Preventative Services Task Force made a recommendation statement on screening for celiac disease. And in particular, they were interested in those kids who are asymptomatic. Okay? And the USPSTF really found that there was inadequate evidence. I mean, that's the bottom line. Inadequate evidence on how accurate the screening tests are for celiac disease, meaning we'll have quite a few false positives. There's not enough evidence in terms of the potential benefits and harm of screening versus not screening. Or even like whether or not we should be doing a targeted screening, like I talked about, based on genetic risk or based on symptoms versus universal screening, meaning just testing everyone. And there's also inadequate evidence for the potential benefits and harm of treating these screen-detected cases. So, this is a call for more studies. I mean, there's a lot more we need to learn about this. And, the call to studies are things like, trying to understand the effects of a gluten-free diet on individuals who are asymptomatic. We need to understand the natural history of asymptomatic celiac disease. That's really, really important. And we need to understand the positive and negative impacts of actually doing screening on the general population. Another study that we're involved in now is called the ASK study. This is in Colorado again, and ASK stands for Autoimmunity Screening for Kids. And this is it's a screening initiative to pick up early type 1 diabetes and celiac disease for kids from ages 2 to 17. This is by doing autoantibody testing. And it's funded by the JDRF, the Juvenile Diabetes Research Foundation, and the Helmsley Charitable Trust. And anytime there's diabetes studies, we always try to add on celiac disease to this because the genes are shared largely by celiac disease and diabetes. And the goal is to screen 55,000 kids over the next 3 years. And so we're going to be picking up a lot of kids over these next few years, especially if the incidence is 1%, 2%, or even 3%. The purpose of ASK is really to test the feasibility of mass screening for type 1 diabetes and celiac disease together. And to date, we've screened 1,800 kids. 55 of these kids are already TTG antibody positive, that's 3%. And about half of them have really high levels, so they likely have celiac disease, and we still have more kids that are coming in for their confirmation visit, meaning we do the initial screening on site, they could be antibody positive, they come back in for a secondary test to make sure that this is truly positive. So from there, this study is going to let us really look at the impact on children and families on finding out that they're antibody positive, especially when they're asymptomatic. Okay, and there's certainly going to be a follow-up study on this. We can't just identify these kids, we got to study what happens to them. We got to look at the outcomes of these kids. And there is going to be a follow-up study, and this is going to let us look at the natural history of these asymptomatic kids. We can look at the quality of life in these kids who have celiac disease, and we can also start to look at the costs associated with mass screening. So, in summary, there's certainly a lot of reasons why we should consider mass screening for this. But obviously, we need to learn a lot more about the potential benefits and harms of doing this. And hopefully the ASK study is going to let us start to answer these questions. Yeah, thank you very much for your time.